Hello guys. This is Dr. Rizwan Mirza. Welcome to my channel at Dermatologist.
Hello guys. There is another deadly virus after COVID that is spreading in the country. Multiple people have been diagnosed in 2 cities in Pakistan. 4 people including 2 doctors who were the treating physicians have died of the virus. It is an alarming situation and high alert has been initiated all over country, especially both the cities that were presented with the viral cases to control the spread of the deadly virus. Let's discuss the Crimean-Congo Hemorrhagic virus. Crimean-Congo Hemorrhagic fever is caused by Crimean-Congo Hemorrhagic fever virus. This virus is a member of the genus Norovirus in the family Bunyaviridae. It belongs to the CCHF serogroup. Although early serological studies revealed very few differences between strains of Congo virus, nucleic acid sequence analysis has demonstrated extensive genetic diversity, particularly between viruses from different geographic regions. Crimean-Congo Hemorrhagic fever virus is widespread in Africa, the Middle East and Asia. It has also been found in parts of Europe including southern portions of the former USSR like Crimea, Astrakhan, Rostov, Uzbekistan, Kazakhstan, Tajikistan, Turkey, Bulgaria, Greece, Albania and Kosovo province of the former Yugoslavia. The disease was first characterized in the Crimea in 1944 and given the name Crimean hemorrhagic fever. Illness was detected in about 200 Soviet military personnel assisting peasants in the area following the Nazi invasion. It was then later recognized in 1969 as the cause of illness in the Congo, thus resulting in the current name of the disease. New outbreaks have occurred in recent years. The Congo virus is also a potential bioterrorist agent. It has been listed in the US as a CDC NIAID Category C priority pathogen. Crimean-Congo hemorrhagic fever virus was first reported in Pakistan in 1976, but the number of cases has shown a dramatic rise since 2000 with 50 to 60 cases being reported annually. The incidence of Congo virus peaks in June and October, but cases occur throughout the year. During 2012, total of 68 Congo hemorrhagic fever alert were given involving 141 suspected and 49 laboratory confirmed human cases resulting in 16 deaths. During 2013, total of 150 human samples were received by the NIH for Congo hemorrhagic fever testing. Out of them 60 are positive while among them 12 patients died. On epidemiological analysis, the exposure of bulk of cases was traced back to animals in Quetta, in different districts of Baluchistan. Similarly, a number of patients diagnosed in Karachi and other cities also possessed history of contact and slaughtering animals. Congo virus shows seasonal trend and peaks during fall and spring seasons, associated with life cycle of ticks, exposure of newborn animals, exposure of migrating animals, and human contact with viremic animals during slaughter and ticks during handling. The people exposed to the virus have occupational history of being a farmer, shepherd, veterinarians, abattoir workers, laboratory workers or healthcare workers. Sometimes the virus spread due to the recreational exposures, like during hiking or camping. People with Congo virus have a mortality rate between 10 to 80%. The highest mortality is after tick bites. The occurrence of this virus is correlated with the distribution of Alamat species, which is the principal tick vector. Other vectors that can carry and transmit this virus includes ixoid ticks, Rhipicephalus, Buphalus, and Dermacentaur. The virus is transmitted to human by tick bites, contact with infected, crushed ticks, contact with infected animal tissues, ingestion of unpasteurized milk, contact with infected people blood, and also via horizontal transmission. The incubation period is influenced by the route of exposure. Infections acquired via tick bites usually become apparent after 1 to 3 days. The longest incubation period reported by this route is 9 days. Exposure to blood or tissues usually results in a longer incubation period. Current estimates suggest that these infections become apparent, on average, after 5 to 6 days, but incubation periods up to 13 days are known. The viral disease takes the course and has 4 phases. pre-hemorrhagic phase, convalescent phase, and the recovery phase. The first sign of Crimean-Congo hemorrhagic fever is a sudden onset of fever and other nonspecific symptoms including chills, severe headache, dizziness, photophobia, neck pain, myalgia and arthralgia. Gastrointestinal symptoms including nausea, vomiting, non-bloody diarrhea and abdominal pain are also common. Sharp mood changes, confusion and aggression have been reported in some cases. Cardiovascular changes such as bradycardia and low blood pressure can also occur. The hemorrhagic phase develops suddenly. It is usually short, lasting on average 2 to 3 days. A petechial rash may be the first symptom. The rash is followed by petechia, ecchymosis and large bruises on the skin and mucous membranes. Hematemesis, melena, epistaxis, hematuria, hemoptysis and bleeding from venipuncture sites are also common. Bleeding can occur in other locations, including the brain. In one case, internal bleeding mimicked acute appendicitis. Hepatitis occurs in some patients, and may result in jaundice and hepatomegaly. Splenomegaly can also be seen. In the patients who survive, recovery begins 10 to 20 days after the onset of illness. The convalescent phase is characterized by generalized weakness, a weak pulse and tachycardia. Other symptoms including sweating, dryness of the mouth, headache, dizziness, nausea, poor appetite, labored breathing, polyneuritis, poor vision, loss of hearing, and memory loss have also been observed. Some patients temporarily lose all of their hair. Hepatorenal insufficiency has been reported in some countries but not others. Recovery is usually complete but slow, and can take up to a year. For the diagnostic purpose, virus isolation must be carried out in maximum biocontainment laboratories, that is BSL-4. Crimean-Congo hemorrhagic fever can be diagnosed by isolating the Congo virus from blood, plasma or tissues. At autopsy, the virus is most likely to be found in the lung, liver, spleen, bone marrow, kidney and brain. Crimean-Congo hemorrhagic fever is often diagnosed by reverse transcription polymerase chain reaction assay or on blood samples. This technique is highly sensitive. Viral antigens can be identified with enzyme-linked immunoassay or immunofluorescence, but this test is less sensitive than PCR. These tests detect Congo hemorrhagic fever-specific IgM, or IgG titers in acute and convalescent phases. Other serologic tests such as complement fixation and hemagglutination inhibition were used to diagnose Crimean-Congo hemorrhagic fever in the past, but lacked sensitivity. In fatal cases, patients generally die without developing antibodies. For assessing the patients and identifying critically ill patients, patient triage is done and patients are divided into 3 categories. Category A, B and C. Category A include those patients that have relatively mild disease, with fever less than 38.5 centigrade, no systemic bleeding, SGPT levels less than 150, platelet count greater than 50,000. These patients improve spontaneously in about 10 days of illness. Patient can be managed with supporting therapy and regular monitoring for worsening of symptoms. These patients do not require ribavirin. Category B include those patients who are in the first 5 days of illness and are severely ill with high-grade fever that is greater than 38.5 centigrade, patient with local and systemic bleeding manifestations, patients having SGPT levels of 150 or more, or patients with platelets less than 50,000 or APTT of 60 seconds or more. Even if the patients still look comparatively well at this stage, these clinical symptoms and lab values are markers of poor prognosis, if recorded during the first 5 days of illness. Hence, persons in this group should be treated as soon as possible with ribavirin, as early treatment respond remarkably well to ribavirin. Category C include patients who are first seen and diagnosed as case of Congo hemorrhagic fever after day 5, and they are in comatose or terminal state with DIC and multi-organ failure. Treatment with ribavirin is indicated, but the prognosis is very poor. The treatment of Congo virus includes supportive measures, which is the mainstay of patient management in Congo virus. It includes intensive monitoring to guide volume and blood component replacement, fluid management by intravenous crystalloids, oxygen, cardiac monitoring and administration of blood and blood products is clinically indicated. Precautions are made to avoid intramuscular injections and use of aspirin or other anticoagulants. Minimize invasive procedures because of the risk associated with viral transmission from sharp objects. If the patient meets the case definition for probable Congo hemorrhagic fever, oral ribavirin treatment protocol needs to be initiated immediately. Ribavirin can be given via intravenous or oral route. The best way to avoid being infected with Congo virus is to take prevention, including avoiding tick bites. Measures to avoid tick bites include using tick repellents, making environmental modification by using insecticides, avoidance of tick habitat, examining the skin and clothing for ticks. Clothing should be chosen to prevent tick attachment. Long pants tucked into boots and long-sleeved shirts are recommended. Acaricides can be used on livestock and other domesticated animals to control ticks, particularly before slaughter or export. While handling the samples, contact with infected blood or tissues should also be avoided. Protective clothing and gloves should be worn whenever skin or mucous membranes could be exposed to viremic animals, particularly when blood and tissues are handled. Unpasteurized milk should not be consumed. In meat, Congo virus is usually inactivated by post-slaughter acidification. It is also killed by cooking. Congo virus can be inactivated by disinfectants including 1% hypochlorite and 2% glutaraldehyde. It is also destroyed by heating at 56 degrees C for 30 minutes. It is important to note that preventing tick bites, early diagnosis, and isolation of infected individuals are important strategies for managing Congo virus. Additionally, healthcare workers and those at higher risk of exposure should be aware of the disease and take appropriate precautions to reduce their risk of infection. If you have any questions or query, do leave us a comment.
Subscribe to my channel at YouTube at Gertologist and press the bell icon for updated video. You can also follow my page at Facebook and follow me on Instagram. And if you like the video, don't forget to like and share the video.